Adthyza for the treatment of hypothyroidism. Here are objectives. Okay, to start things off with some reassurance, I wanted to say that you're not lazy, you're just hormonally misunderstood, and Adthyza gets it. So what is hypothyroidism? Hypothyroidism occurs when an underactive thyroid gland causes thyroid hormone deficiency, which ultimately leads to slow metabolism. The most common reasons for this are Hashimoto's disease, iodine deficiency, or from a thyroidectomy. Some other risk factors can be genetics or family history, autoimmune diseases like type 1 diabetes, and female sex. Some symptoms of hypothyroidism include hair loss, brittle nails, intolerance to cold, dry skin, weight gain, and bradycardia. There are three types of hypothyroidism that depend on the organ of origin. Primary is the most common type and occurs in the thyroid gland directly, causing an increase in thyroid stimulating hormone and deficiency in free T4. Secondary hypothyroidism involves pituitary dysfunction and results in a deficiency in both TSH and free T4. Lastly, tertiary occurs in the hypothalamus, which produces TRH, and is the least common type. It results in a cascade of deficiency in TRH, TSH, and T4. When it comes to clinical practice guidelines for hypothyroidism, according to ATA AACA or CE, the standard treatment would be levothyroxine monotherapy. And actually, TE, NTEs like Adthyza are not routinely recommended as first line due to the inconsistent T3 levels and adverse effects. Adthyza contains both T4 and T3 and is only utilized in select patients who are not responding to T4 monotherapy. For dosing of Adthyza, start the patient on 15 to 30 milligrams daily and adjust this every 2 to 3 weeks. It is important to monitor TSH, free T4, and the clinical response. Adthyza should be used with caution in elderly or those with cardiac issues. So what is it? Adthyza is a non-synthetic desiccated thyroid extract or natural thyroid extract. It is actually derived from pig thyroid glands and contains both T4 and T3 hormones. So why is this so special? As an alternative to traditional DTEs, Adthyza offers consistent hormone content and modern quality controls. It is also available in multiple strengths from 15 to 120 milligrams. Since Adthyza is not actually FDA approved for thyroid hormone replacement therapy due to limited recent clinical research, there are certain indications for use, these being hypothyroidism of any cause except transient types, a patient's lack of responsiveness to T4 treatment alone, and hormone TSH suppression in goiters and thyroid cancer. For the mechanism of action, T3 acts on nuclear thyroid receptors, which affects gene transcription by interacting with DNA at thyroid response elements. This then increases metabolism, energy production, and oxygen consumption.
Now we'll move on to the clinical data evaluating Adthyza. The study compared desiccated thyroid extract, also DTE, to levothyroxine using a randomized double-blind crossover design. Each participant received both treatments, allowing for direct comparison while minimizing individual variability. The objective was to assess whether DTE provided superior symptom control, cognitive improvement, or overall patient satisfaction in individuals with hypothyroidism. Patients were assigned to either DTE or levothyroxine for 16 weeks, followed by crossover to the alternate therapy for another 16 weeks. This study was designed with 80% power to detect a clinically meaningful difference in symptom scores. A total of 78 participants were randomized, with 70 completing the full protocol. Data was collected at baseline and after each treatment period, including lab results, symptom questionnaires, and cognitive assessments. Inclusion criteria focused on adults aged 18 to 64 with primary hypothyroidism and stable TSH levels on levothyroxine for at least 6 months. Patients with cardiac conditions, pregnancy, or other confounding medical issues were excluded, ensuring a well-defined study population, though potentially limiting broader relevance. The majority of patients were female, 76%, with a mean age of approximately 51 years. Most were Caucasian, and Hashimoto's thyroiditis was the predominant etiology. This demographic is representative of the typical hypothyroid population seen in clinical practice. So primary endpoints included patient-reported outcomes using the GHQ-12 and thyroid symptom questionnaire, as well as neurocognitive testing. Secondary measures assess changes in body weight, thyroid hormone levels, and patient treatment preference. Appropriate statistical methods were employed, including linear mixed models and chi-square testing. The study found no statistically significant differences between DTE and levothyroxine in terms of quality of life, symptom control, or cognitive performance. However, patients treated with DTE experienced a modest average weight loss of approximately 3 pounds. Notably, 48.6% of patients expressed a preference for DTE compared to 18.6% for levothyroxine. No serious adverse events were reported. Minor transient effects such as palpitations and nervousness were observed, but none led to study discontinuation, indicating both therapies were generally well tolerated. In summary, while DTE did not demonstrate superior efficacy in symptom or cognitive outcomes, it was associated with modest weight loss and higher patient preference. These findings suggest that DTE may serve as an alternative option for patients who remain symptomatic or dissatisfied with levothyroxine monotherapy. The study's strengths included its rigorous design and comprehensive assessment of clinical, biochemical, and cognitive outcomes. However, its relatively short duration and focus on a mid-age, relatively healthy cohort limit relevance to broader, more complex patient populations.
The second study we will be presenting was authored by Shakir and colleagues and published with the DOI listed at the bottom of the slide. The purpose of this study was to evaluate symptom relief, cognitive function, mood, and patient preference across 3 different thyroid replacement strategies, including levothyroxine alone, abbreviated as LT4, a combination therapy with levothyroxine and liothyronine, or T4 plus T3, and desiccated thyroid extract, also abbreviated DTE. This was a random, double-blind crossover trial including 75 hypothyroid patients. All of the patients were biochemically euthyroid at baseline, meaning that their labs were normal, but they were still symptomatic. Each patient completed 22 weeks on each therapy, and the outcomes were measured using 3 main tools. The first being a 12-item general health questionnaire, which assesses psychological well-being. The second being thyroid symptom questionnaire, which measures hypothyroid symptom severity. And the last being a Beck depression inventory, which evaluated depressive symptoms. The patients were randomized into 3 groups: LT4 alone, combination LT4 plus LT3, and DTE. After 22 weeks on one therapy, the patient was crossed over to a different treatment group. The significance level was set at 0.05, which was significant. And while the statistical power wasn't formally reported, the crossover design helped strengthen the study by allowing each patient to serve as their own control. So after the first weeks on the treatment, a serum TSH level was checked and the dose was adjusted accordingly. Once the TSH level was at goal, patients continued the medication for additional 16 weeks. Thereafter, the patient was crossed over to the next treatment group. So measurements were obtained at baseline and then again at the end of each study period for each treatment group. Hypothyroidism symptoms were then self-assessed by the patients with the 12-item general health questionnaire, the thyroid symptom questionnaire, and the Beck depression inventory. In terms of inclusion criteria, the study enrolled adults between 18 and 65 years old who were stable on L4 therapy but still dissatisfied with their symptoms. These patients needed to have a normal TSH level, and exclusion criteria included those with unstable medical or psychiatric conditions, pregnancy, or recent changes to their thyroid medication. This study measured several endpoints, including the symptoms with the TSQ-36, the mood with the depression inventory, and quality of life with GHQ-12. If you recall the purpose, which was to evaluate the symptom relief, cognitive function, mood, and patient preference across these three drugs, this figure shows how symptoms, quality of life, and general health, cognition and memory, and mood change switched from T4 alone plus T4 plus L3, LT3, and then DTE. It found that patients with higher symptoms on LT4, noted as the H group, had the highest improvements across all measures, including thyroid symptoms, general health, memory, and depression score. These changes were statistically significant, especially in the high symptom group, with p-values less than 0.001. This suggests that patients who remain highly symptomatic on LT4 may benefit the most from combination therapy. Notably, the patients who were most symptomatic tended to benefit the most from switching to DTE as well. Statistical analysis involved related to ANOVA for continuous outcomes and chi-square tests for analyzing patient preference. This study concluded that there were highly symptomatic patients who on LT4 alone saw improvements after switching to either LT4 plus LT3, a combination therapy, or to DTE like Adthyza. The improvements were better on symptom control, better general health, better memory, and better mood. The greatest improvements, again, were seen in patients who had the highest symptom burden. Overall, this study supports a more personalized, patient-centered approach to managing hypothyroidism. There are some critiques of this study to mention. It had a pretty small sample size and treatment duration, which limited its strength. Each treatment phase was relatively short, and outcomes were based on subjective symptom scores rather than hard clinical endpoints. There was also selection bias since the study mainly enrolled healthy, stable patients, limiting how well the findings can actually be generalized. And finally, the study didn't directly assess newer formulations of DTE, such as Adthyza. Still, the takeaway is that individual thyroid therapy, including DTE, can positively impact patients' outcomes compared to traditional hypothyroid therapy. It is notable that no serious adverse events were reported, although some patients did have increased heart rate with DTE, but no significant weight or bone metabolism effects.
So next we'll be going into the analysis and the cost differences between Adthyza and similar medications. Armour thyroid and MP thyroid are also both naturally desiccated thyroid medications that act in the same way that Adthyza does. The main differences between these three medications are their inactive ingredients. The cost differences between these NTT medications are pretty insignificant. As you can see, based on the average monthly cost, the total difference between them is only $2.15, which comes out to about 7 cents a day. And then when we compare Adthyza to levothyroxine, the current drug of choice for hypothyroidism, there is a significant price difference. On average, the difference between the monthly cost comes out to $19.71, and the daily to just $6.57. This is almost about 2.5 times more expensive. However, the total monthly cost for Adthyza is still relatively affordable to most. But again, if cost is a large concern, levothyroxine would be the cheaper option. Synthroid is the brand medication to the generic levothyroxine, so many patients do prefer Synthroid to levo. So I added that in my analysis as well. But in conclusion of the pricing analysis, Adthyza, when compared to other similar medications to treat hypothyroidism, is pretty much in the middle of the price range when it comes to average monthly and daily costs. Although it is still fairly inexpensive, it is definitely something to keep in consideration when deciding what to choose for treatment in your patients. Other clinical considerations to keep in mind are efficacy and safety. The information available on Adthyza is very limited with no large clinical trials, and it is not FDA approved. Based on our research, most of the outcomes we have found were based on the patient saying how they felt and not much evidence backing it up. However, it is considered a relatively safe drug. There are some precautions for patients with hypertension, diabetes, and heart disease because of the adverse cardiovascular events. Similar to other hypothyroid medications, there is a risk of overcorrection leading to hyperthyroidism. And we already discussed pricing, so we're going to continue to our recommendations for Adthyza. So we concluded that Adthyza should only be used as a second-line therapy, mainly based on the lack of high-quality results on benefits with the use of this NDT drug. The hormone fluctuations and difficulty with dosing can cause both palpitations and inaccurate monitoring. For these reasons, it is recommended that levothyroxine remain the first-line medication to treat hypothyroidism. Only if the patient has a preference for non-synthetic thyroid hormone, has a hormone conversion impairment, or a past use of NDT should Adthyza be prescribed first line. And then here's our references.